Okay, is this too loud? Too quiet? Just right? All right, thanks Goldilocks. So for those of you who I haven't met, my name is Max Lebo. I'm I'm an assistant professor in the Division of Cardiology, the section of heart failure transplantation. And most of you guys have probably met before, but I'm a pretty informal guy, so if you guys have questions throughout the talk, don't hesitate to just raise your hand or even just shout out, okay? Today, as I was just telling Vic, I've got a number of these kind of talks that I've designed. Today I was going to be, I thought I'd just present to you guys sort of the diagnosis and management of heart failure patients as outpatients. In the future, I'd like to be happy to come back and talk more about the inpatient management of decompensated heart failure. But for today, we're going to stick with just how you guys are going to take care of these patients in the clinic and what sort of different things we have for diagnosis as well as for treatment. So I have to point this in a certain direction, or I have to point it at this guy? All right. So I have no disclosures pertinent to this talk. Necessary, obligatory slide. Before we get into sort of the management of heart failure, I think it's really important in knowing how to diagnose it. And really, to do that, you have to really have a good definition of it. So I want to start just by saying heart failure is not a disease. Okay? Heart failure is actually, it's a very complex syndrome that results from any impairment in left ventricular filling or ejection of blood. And that can result from basically any kind of disorder related to the pericardium, myocardium, endocardium, valves, even the great vessels. And so when we think about heart failure, we have to realize that, well, we label all many different kinds of patients with heart failure. It's a very heterogeneous syndrome, and we got to figure out a way to then, to better label or better identify patients that have heart failure with what their underlying disease process is and what kind of medications and what kind of therapies they may benefit from. So for the first thing that we do when we figure somebody's got heart failure, we think that they have heart failure, we want to assess their ejection fraction to figure out if they have reduced ejection fraction or preserved ejection fraction. And that's very important because it has implications not only for determining what the underlying etiology of the disease may be, but also in terms of what kind of therapies they're going to respond to or are likely to respond to. You guys are probably all fairly well versed in the workup of the different kinds of cardiac diseases that can cause heart failure. I just threw this in here in the slide, and this will be available for you guys on YouTube, it sounds like, to kind of go over. But this is a fairly comprehensive, although not maybe totally exhaustive list of the different kinds of etiologies of both HFrEF and HFpEF. It's important to note that the most recent guidelines define HFrEF as having an ejection fraction less than 40%. And that's largely based off of the studies that have shown benefit from medications for HFrEF are all those that enrolled patients with EFs less than 40%. And we don't have a whole lot of therapies, as we'll get into. We don't have a whole lot of therapies that have been shown to benefit patients, specifically the heart failure side of things, if their ejection fraction is over 40%. So that's kind of the cutoff we have for HFrEF. That said, HFpEF is defined as having an ejection fraction over 50%, which then leaves this sort of gray zone of, well, what if you got an ejection fraction of 45%? The most recent guidelines that were they were published in 2013 characterize anybody with an ejection fraction between 40 and 50% as having HFpEF, with the caveat that it's considered borderline, or if the patient had previously had a low EF that had recovered, so they previously had an EF of 35% but then put on medical therapies or given a stent or whatever it was, they recovered their EF to be more than 40%, they then actually get a new diagnosis, a new label as a HFpEF recovered. The importance of that is really, again, trying to determine what the medical therapies are. If you look over this list of the different etiologies, you will notice that while there are some that predominantly cause HFrEF and some that predominantly are associated with HFpEF, that some of the etiologies, there's some overlap. So ischemic disease, you can have patients who have ischemic cardiomyopathy with a normal ejection fraction, valvular heart disease, patients with heart failure due to mitral regurgitation or due to aortic stenosis who can have HFpEF or then later in the course develop HFrEF. Similarly, hypertension, which is probably the number one cause for HFpEF, can lead to HFrEF as well. So it's not a cut and dry, real clean picture all the time. But that said, it's important to recognize that there are different etiologies. We want to look for the underlying etiology, the underlying disease state that has caused heart failure, because not only would we then be treating the heart failure, but we also want to make sure we're treating the underlying disease state. So for the diagnosis, and if you read through the exhaustive 2013 guidelines, they go through sort of what the class of recommendation is for all the different steps of the diagnosis. H&P gets a class 1 recommendation, not just for a little, just asking about their breathless symptoms, but really a fairly compulsive history and physical, both to delineate the different symptoms that are classic for heart failure, as well as some of the more atypical things. So when we think classical heart failure symptoms, we think of dyspnea, fatigue, PND, orthopnea, edema. But other things to tease out in patients who may have more right-sided symptoms, look for abdominal complaints, nausea, bloating, just abdominal discomfort, early satiety, loss of appetite, things like that. As well as going through a pretty thorough family history. You want to make sure you identify any patients that may have a familial cardiomyopathy, so do a very close sort of family history directed towards first-degree relatives, mom, dad, brothers, sisters, siblings, and children. And then, of course, social history is pretty important as well. So you want to make sure that we're teasing out any kind of bad habits or any kind of risk factors they may have socially in terms of drugs, alcohol is a big one, and the like. So a very thorough history and physical gets a class 1 recommendation, level of evidence B. When you get to your sort of laboratory studies, probably the best study to really decide about, to help you and you're making your diagnosis of heart failure is the BNP. And the BNP does get a class 1 recommendation at the time of initial diagnosis, especially if the diagnosis is uncertain, to sort of help you make that determination. We want to make sure that, we're evaluating patients that are coming with dyspnea, make sure we exclude other things that could cause dyspnea, like pulmonary disease, anemia, obesity, deconditioning, things like that, before we label somebody as heart failure. And a BNP can sometimes be very helpful. So you guys are all familiar with BNPs. A level below 100 is usually pretty good for saying this patient their symptoms are probably not related to heart failure, although there are some places that will fall apart. Particularly patients with renal disease, with advanced renal disease, patients who are obese may have either a high or a low BNP that doesn't really correlate quite so much with their heart failure. But if they've got a level over 500, definitely if it's over 1,000 and you are suspecting heart failure, it's fairly good for making the diagnosis of this is heart failure. Again, you've diagnosed the syndrome, you haven't necessarily diagnosed the underlying disease, so there's still more work to be done. That's where echo comes in. Echo gets a class 1 recommendation, should be done in every single patient who you suspect for having heart failure. The echocardiogram is good for not only assessing ejection fraction, but also for looking for what the underlying cause of disease might be. Is there evidence of coronary disease? Is there segmental or regional wall motion abnormalities? Are there valvular abnormalities? Is the pericardium? Is there suggestion of diastolic dysfunction? Is there suggestion of pericarditis or constrictive pericarditis? So there's a lot you can get from the echo. And the echo gets a class 1 recommendation for any patient who you're concerned or suspect that they have heart failure. That said, there's also a lot of people that will follow annual echoes. You'll see this especially a lot of times for patients who are coming from outside in the community. And then a question may come up, your patients who you see in clinic may ask you, I haven't had an echo in a year, do I need another echo? It's actually a class 3 recommendation or no benefit and not recommended to just order annual echocardiograms or serial echocardiograms at some other sort of time point, unless you have a change in the patient's clinical condition that's not otherwise explained by some other kind of behavior, some other kind of something else going on. In that case, if there is a change, then there is another class 1 recommendation to get the echo. But in the absence of that, we don't recommend routine reassessments of echo. The only other time that I routinely will order an echo is if I've started a patient who is diagnosed with reduced EF, on some sort of medical therapies or device therapies, and I want to know whether or not they've had any response to those therapies. That also would be a class 1 recommendation because it will guide further decisions, whether or not to place the defibrillator or whether or not they are a candidate for a CRT device, as we'll get into a little bit later. So, but barring that, if the echoes, if you're thinking about just ordering an echo just to see if things have changed at all without any good reason to, don't order it. The MRI gets so cardiac MRI is actually, it's a phenomenal test. But that said, it's really only indicated in a couple of scenarios. One is for the patient who you can't get good echo windows on. So if your TTE is not adequate for figuring out what the ejection fraction is or what the left ventricular volume is, then the MRI is a class 1 recommendation in that setting as sort of your second line to the echo. A place where the MRI still gets a 2A indication for ordering, and where I still frequently order the MRI, even if the echo has told me a lot, is in patients with non-ischemic cardiomyopathy, when I'm looking to see if I can find some eye to what the underlying diagnosis is. The MRI can give you a lot better look at the myocardial substrate to see if there's any evidence that the patient has an infiltrative disorder. It can show you, it can give you suggestion about whether or not this is a myocarditis or sarcoid. It can be good for looking for iron deposition. It can be looking for amyloid. And finally, the MRI also can give you a lot of information in terms of prior infarct, if there's areas of scar in a vascular distribution that makes sense with a coronary territory, as well as viability. So if you see on the MRI there's a lot of scar, there's a lot of fibrosis in the MRI in the LAD territory, then if your question was, should I be sending this patient for revascularization, for bypass surgery of that vessel, you may not, it may lean you one way or the other if it looks like the territory is viable or not. So the MRI can be very valuable in that way. I don't have on here other viability studies, but there are historically, so the dobutamine echoes can be used, although they're probably not quite as good. Same thing with some of your nuclear studies, although the PET rubidium or the PET nuclear studies are also fairly good for looking at viability in patients who have some other reason why they can't undergo an MRI. But I tend to look at the MRI as the best assessment for viability. Cardiac catheterization gets a class 2A recommendation for the evaluation of anybody who's got suggestion of coronary disease based off of either a drop in their EF or typical symptoms to go along with that, and with the caveat they also have to be a candidate for revascularization. There's really no reason to do a cardiac catheterization in somebody if you know that for one reason or another that they can't be revascularized, whether it's due to advanced age or comorbidities or for any other reason. And there's actually a fair amount of data that suggests that cardiac catheterization is actually underutilized in the heart failure population. Where I trained, we were taught that anybody who's got a new drop in their EF deserves a cardiac cath unless their creatinine is, prohibitive. Actually in the real world, when we look at studies, it looks like probably less than maybe 20 or 30% of patients with a new diagnosis of a low EF do get a cardiac catheterization. So again, the most recent guidelines do point out that while not everybody is it indicated for, it's probably is underutilized. Endomyocardial biopsy, similar to cardiac catheterization, is something that should be considered in somebody where you actually have the diagnosis is suspected. So if you have a diagnosis that you suspect, like amyloid or a giant cell myocarditis or something that actually would change your management, then the endomyocardial biopsy gets a class 2A recommendation. That said, it should not be used in sort of the routine assessment of heart failure patients, because of the, as you guys are all aware, endomyocardial biopsy comes with significant risk. And so it gets a class 3 recommendation for potential harm in just your routine evaluation of heart failure patients. But that said, it can be a very valuable test in the correct setting. So if you suspect a diagnosis that will change your management and that diagnosis is only going to be made by endomyocardial biopsy, then the biopsy is indicated. So when the patient shows up to you, see you in clinic, whether it's the first time they're showing up or if it's just a known heart failure patient that you're following, and for those of you who've followed with me or have been in my clinic, there's some very important things that we make sure we assess every single time a heart failure patient comes into clinic. In particular, you got to make sure that we get vitals on these patients. You can learn a lot just by looking at the patient's vitals. So a lot of these patients may have uncontrolled hypertension. They may have arrhythmias. They may be tachycardic. So these are things you want to look for. On the flip side, there are patients who there are definite signs you can find for cardiogenic shock in patients who have known heart failure and are coming in with borderline blood pressure, hypotension, tachycardia, narrow pulse pressure. These are all things that I'm always looking at, both in terms of trying to assess what the current status of the patient is, as well as what kind of medical therapy I might be able to further optimize during that visit. As far as physical exam findings, jugular venous pressure or the jugular venous pulsation in the neck, as well as putting pressure on the abdomen to look for abdominal jugular reflux, those are by far your most sort of sensitive and specific findings you're going to be able to elicit from a patient who has decompensated heart failure, that is, who's got elevated filling pressures to suggest that they have either excess intravascular volume or that their cardiac output is low and that they're unable to keep up with, they're unable to unload the heart. The jugular venous pulse, as you guys are probably all very aware, is best identified with the patient at sort of the 30 to 45 degree angle, with them sort of slightly turning their head to the left, and often using kind of ambient or lighting will help elicit that. Now the difference between the jugular venous pulse and the carotid pulse is actually pretty distinct for most patients. A carotid impulse should look more like a single outward impulse, whereas the jugular venous pulsation should be a double waveform, and is usually what you're looking for is the X and Y descent. So it's actually a down-down as opposed to a single out. If you have difficulty identifying it, which in a lot of patients it is difficult to identify, then there are some maneuvers you can use. One thing is you can raise and lower the head of the bed to see if that'll tease out where there's a clear jugular venous impulse. The other things you can do is assessing for the abdominal jugular reflex, putting pressure on the belly, seeing if that can help tease out, if you can see a rise from where you thought you might have seen it. If that rises with that impulse, that's not a carotid impulse, that's the jugular venous impulse. And then finally, one thing that I often will do is you can even put a little bit of occlusive pressure. If you just put sort of light pressure just above the clavicle, and that abolishes your waveform, then that's most likely a right atrial waveform or a jugular venous pulse that you're seeing there when you release that a carotid impulse should not go away with just light pressure over just above the clavicle. So that's very important. The last piece I'll say on these is that the correct way to assess for abdominal jugular reflux is not just to push with a little bit of pressure in the belly for 1 second, and if you see it go up, then call it, yes, they have AJR. It's actually that you need to put the pressure on the abdomen and wait for a good about 20-30 seconds. And only if it stays, it's an elevation that persistently stays up higher with pressure is what's considered a positive AJR. If I pushed on Lonnie's belly right now, I could see it go. I could see your JVP go up for a second, but if it should fall within a few seconds or within 10 seconds anyway, that would mean that it's not a positive AJR. Only if there's a sustained increase with a prolonged pressure in the belly do we call that a positive AJR. Obviously, we also examine the lungs, specifically looking for pulmonary edema, which can manifest as pulmonary rales or crackles. That said, that's a fairly non-specific finding, much like our chest x-rays, which can often look clear in patients who have chronic heart failure. So a clear lung exam does not rule out heart failure. The other thing to look for is pleural effusions. It's not uncommon for these patients to have pleural effusions, so decreased breath sounds at either one of the bases. Typically it's the right side, but you can have either side can have a pleural effusion, as well as percussing for dullness is also important. In terms of the abdomen, we look for ascites, we look for hepatosplenomegaly, evidence that the right atrial pressure is high and that the systemic venous pressure is high, leading to engorgement of the liver and the spleen. And then when you get out to the periphery, we're assessing not only for edema and for pulse amplitude, but we're also assessing, it's one of the first things I do when I assess a patient is just try to get a feel what their distal perfusion is. So just putting the back of my hand on their shin, if that's nice and warm, most likely this patient's well perfused. If it's cool, then I kind of march my hand up to their thigh and assess to make sure that the patient's not cold. If they're cold, if they've got a narrow pulse pressure and marginal, they have a low blood pressure and they're tachycardic, those are all signs the patient's in cardiogenic shock. And often you can diagnose this, we should be able to make a diagnosis of cardiogenic shock without a Swan-Ganz catheter. You should be able to do so just in the clinic, just in this physical exam. As far as the routine evaluation of labs, for any patient that's on diuretics, we haven't got to meds yet, but patients who are on diuretics or patients who you're up titrating their ACE inhibitors, ARBs, or their ARNIs, which we're going to talk about all these meds in a little bit, those patients should have a fairly routine reassessment of their basic metabolic panel plus or minus their LFTs, really to look at renal function, look at potassium levels, look at sodium levels, as well as to look at, for patients you're concerned may have congestive hepatopathy, to look and see, make sure their livers are not being too inundated with fluid. The evaluation of a heart failure patient in clinic or in the hospital or wherever is not done until you stage and classify them. And the reason for that is that the stages and the classes really help make sure that we're paying attention to what the appropriate medical therapies are for patients and when it's time to refer them on for advanced therapy evaluation. So not to go crazy with this, you guys are all very familiar with the heart failure stages and classes, but the big thing I would point out is that the stage A is really not heart failure. That's patients who are at risk for heart failure. Stage B is when a patient has some sort of structural cardiac abnormality, whether it's LVH or a reduction in their EF, but they haven't developed symptoms yet. We consider that patient stage B, and so when we look at the NYHA functional classification, by definition, a stage B patient is NYHA class 1. Once a patient has developed symptoms, then they progress to stage C, and then depending on their level of compensation, those patients, as you can see by the brackets, patients in stage C can be NYHA class 1 through 4, really depending on how well they're doing, how well their blood pressure, their rhythm, and their volume status is controlled. Once a patient really shows that they're failing their conventional medications and their conventional device therapies, and they're having either frequent hospital readmissions or they've got evidence of low cardiac output, that's when we say a patient has graduated to stage D. And as you can see by the arrows here, the heart failure stages really just progress in one direction. It's very rare for a patient to actually be able to be stage D and then recover enough to then say that they're now stage C. So it's really, we think about the reason the staging system was developed in the first place, which was sort of the mid-2000s, about a decade after the NYHA classification system was developed. The staging system was developed to show that heart failure is a progressive disease, and this is a way for us to keep tabs on patients and make sure that they're being referred for the appropriate interventions at the appropriate times. Whereas the NYHA classification, again, can vary. It's very dynamic, and so a patient who's stage C, who shows up decompensated with class 4 symptoms, you diurese them, and they go back to class 1 symptoms by the time of discharge. You can see that they can go either direction with the classification. And so this just sort of further just opens up sort of highlights the difference between stage C and stage D. And again, patients can be stage C for a long, long period of time, but once they progress, once they're having frequent hospitalizations and they're basically refractory to your normal standard therapies that you give to heart failure patients, that's when we say we've identified a patient with stage D, and that would then be the time, at the first warning that somebody may be stage D is the appropriate time to then refer them on to see a heart failure specialist to see if they are potentially a candidate for more advanced therapies like LVADs and transplants. We're not going to go into those things today, but that's a whole other talk in itself. But things that can identify that, patients when oral therapies are failing, when the patients are, we often will do these cardiopulmonary exercise tests. If we see that their peak VO2 is falling, if we see that they're, at best they're class 3 or class 4 symptoms, even if they're staying out of the hospital, if they're severely limited despite all of our therapies, those are all things that should make us at least consider stage D and refer them on. So, getting into medical management. I'm going to kind of give just a high-level overview here. We're not going to go through every single medication that we specific names of the medications, but more classes of medications for today. You guys are all aware of beta blockers, ACE inhibitors, ARBs, and the mineralocorticoid receptor antagonists, or spironolactone, eplerenone. Those medications between about 1991 and 2003 or so, we had a number of studies that basically showed the benefit of 3 different beta blockers, specifically metoprolol succinate, bisoprolol, and carvedilol, as well as a number of ACE inhibitors, most notably lisinopril, enalapril, and captopril, as well as the ARBs, candesartan, valsartan, and losartan, and the mineralocorticoid receptor antagonist, spironolactone and eplerenone. All those medications in subsequent studies that added them on as each new medication class was recognized to be a good way to attack the neurohormonal imbalance that leads to progressive heart failure. Each one of those studies showed progressive improvement in both morbidity and mortality. And as such, all those medications do receive Class 1 recommendations for any patient who has a reduced ejection fraction. You can see here I have the tables, this slide split up into HFrEF and HFpEF, because unfortunately trials that have looked at those medications in HFpEF patients have not shown any significant mortality and really no significant morbidity improvement in that population. Now that said, if a patient with HFpEF has high blood pressure, we often use ACE inhibitors as the first-line therapy for their blood pressure. But to take a HFpEF patient who's got well-controlled blood pressure and just add on an ACE inhibitor or an ARB or a beta blocker to try to further reduce morbidity and mortality, we have not seen the benefit there. So those medications specifically are Class 1 recommendations for HFrEF and not for HFpEF. Now, in the last few years, we've seen a couple of new medications come onto the market, and the first one, and we're gonna delve more into the ARNIs and then this funny channel or the IF channel blockers in just a little bit. But those medications on the most recent guidelines have now also been there was actually a guideline update in 2016 just specifically to incorporate these new medications into the guidelines, because they have also shown some benefit both for morbidity and then in the case of the ARNIs, also for mortality. Vasodilators, you guys are familiar with the hydralazine nitrate combination, has been shown to improve both morbidity and mortality in heart failure patients who are already on optimal neurohormonal blockers, specifically those who self-identify themselves as African American. But on top of that, even for patients who don't self-identify as being black, they also show an improvement in morbidity with those as well. So patients who, your initial goal when you see somebody who's got low EF heart failure is to get them onto the beta blocker, one of the RAS blockers, and then an aldosterone antagonist. If they still have blood pressure to work with, then there is a reason to go ahead and add on a little bit of the nitrate and hydralazine if you can to further reduce morbidity and mortality. They don't get they get a Class 1 recommendation in African Americans because of the AHAFT study that showed their benefit. They get a Class 1 recommendation as an alternative to an ACE inhibitor or an ARB in a patient who has HFrEF and can't tolerate an ACE or ARB due to some sort of side effect, whether it's renal dysfunction or if it's cough or some other reason they cannot tolerate the ACE or ARB. Then the substitute is the hydralazine nitrate combination. Finally, just before we move past this slide, I have to say that diuretics are the mainstay for volume management of patients who have either HFrEF or HFpEF and evidence of fluid retention. The diuretics have never been shown to actually improve morbidity or mortality, or should they at least not improve mortality. They are very important though for patients who are symptomatic from volume retention, and so as you guys are all aware, probably the majority of our patients who have heart failure will be on at least a little bit of a diuretic. That said, if they don't have volume retention, you don't routinely just put people on diuretics just for the sake of because they have heart failure, only if they actually need help with volume management. Digoxin still shows up in the guidelines as a Class 2 recommendation for an add-on to all these other therapies once you've already got patients on maximally tolerated goal-directed therapy. Digoxin is the oldest medicine we have for heart failure. It's been around for over 50 years. And as you guys probably all remember from medical school, digoxin increases intracellular calcium, and so in that way it seems to work as a mild inotrope. At least it does so in vitro. As far as in vivo, we don't. There's a lot of discussion about whether or not digoxin actually works as an effective inotrope. One of the things it does do, though, it's also it's a blocker of the AV node. So for patients who have atrial fibrillation and don't have enough blood pressure to tolerate your typical AV nodal blockers, digoxin can be used for them for rate control of atrial fibrillation. Inotropes, which we use a fair amount here because this is a tertiary referral center, so we see a lot of advanced heart failure patients. Inotropes do not have a role in the management of patients who are stage C. It's really reserved for those advanced heart failure stage D patients. And inotropes don't have any class 1 recommendations, although they do get a class 2A recommendation for a patient who has evidence of low perfusion and is either a palliative medication or as a use as a bridge to getting them to an LVAD or a transplant. One last thing I'd say about HFpEF before we move on here is that recently there was a post hoc analysis done on the TOPCAT study. The TOPCAT study was a study that randomized patients who have HFpEF to spironolactone or placebo, and it was published about 2 or 3 years ago, and it was essentially a negative study. It didn't show any benefit to adding spironolactone on for these patients. However, in a recent post hoc analysis of this study, they were doing blood tests during the study for a metabolite of spironolactone to make sure the patients were getting good doses of it. And what they found in this post hoc analysis was that the patients who got enrolled in Europe, specifically in Russia, really had no detectable levels of the metabolite. So there was concern that they really were not doing a good job of including the patient may have been included in the study, but were not actually getting the study drug. And so once they just honed in their analysis to the patients in the Americas, they found that there does look like there may be a significant reduction in morbidity and mortality for the patients who got spironolactone versus placebo. So that study, hopefully this should get published in the near future, and if so, we may actually have some evidence that there is a medication. We know that spironolactone is very good it's a normal nodal blocker that does decrease cardiac fibrosis. And so there was a lot of hope that this medication might be beneficial in this population, and it sounds like there may actually be, that may actually work in that way. So stay tuned on that. Hopefully we'll know in the next few months if we actually have our first medical therapy to give to patients who have HFpEF, outside of just treating their underlying disease. So we're jumping in. I want to talk a bit about, I want to spend a few minutes on this new medication class, the ARNI. You guys are also, I think you guys talked about this at one of your journal clubs, and well, not a lot of the patients who are getting admitted to the hospital right now are on the med. More and more outpatients are getting put on this medicine, so more and more you're going to be seeing patients who are getting admitted to the hospital using it. So what are the ARNIs? What is this? It's the medication, the generic name is called sacubitril valsartan. The trade name it's marketed as Entresto, and that's the new name that was given to originally it was called LCZ 696. I talked briefly about it at Grand Rounds last year. If you weren't there, we'll dive into it some more today. The sacubitril valsartan combo pill, it's actually not two different meds put together, but it's actually one med that has on each end of the molecule, one end is valsartan, and the other end of the molecule is actually this neprilysin inhibitor. And so this medicine does all the same things that your angiotensin receptor blocker does, with the addition that it also inhibits a tiny little enzyme in the body called neprilysin. Neprilysin is an enzyme that's responsible for the degradation of a lot of our little small endogenous vasoactive peptides, most notably BNP. So we're all aware that BNP is a small peptide that the body makes that's created within the heart in small granules in the heart, and that gets released when the heart senses that there's more a buildup of pressure when there's stretch on the left ventricle. The reason it gets released is it's sort of the counter-regulatory hormone to your norepinephrine, your endogenous catecholamines, and endogenous renin-angiotensin-aldosterone system. So on one side you've got the renin-deficiency syndrome, the RAS and the sympathetic nervous system that are trying to basically tell your body, we're under attack and we need to work harder and work harder. And then on the other side, you've got your natriuretic peptides that are telling the body, things are going to be okay, just relax, vasodilate, diurese, and basically all the good things, all the protective things that we try to do with our medications is what your endogenous BNP does. Now, in prior studies looking at recombinant BNP or nasiratide, we found that 24 or 48-hour infusions of the IV formulation of BNP did not parlay into any good long-term outcomes. And so for those of you who you may have had a little bit of experience during medical school with nasiratide, you'll notice that we really just don't use nasiratide anymore at all. And that's because the Ascend trial, which was published right around, I think it was in like 2009 or 2010, the Ascend trial basically showed no benefit to a short infusion of BNP in somebody who's getting admitted for decompensated heart failure. That said, what neprilysin does is neprilysin gives people chronic, more of a chronic increase in their BNP levels as an outpatient by inhibiting the breakdown of the endogenous BNP that our bodies make. And in doing so, it decreases normal activation, decreases vascular tone, decreases cardiac fibrosis and hypertrophy, and decreases sodium retention. So this is it's at least the mechanism seems like it would be a very positive thing. So this medication was pitted against enalapril, which is currently one of our guideline therapies that we use, a class 1 recommendation for patients with HFrEF. And in this paradigm study, which was just published about 1.5 years ago, this study randomized HFrEF patients to the current gold standard versus this new medication. And in this study, we found that the composite endpoint of cardiovascular death and heart failure rehospitalizations was significantly reduced in those patients who were getting this new study drug as opposed to just what we currently have as sort of the best available therapies for the patient. Not only did it show this 20% reduction in the composite endpoint, but then when teasing out the secondary endpoints, one of which was just cardiovascular death alone, it showed that it retained that 20% reduction in that for that outcome as well. So this was a very big win for this new medication class, for this angiotensin receptor neprilysin inhibitor. And based on that, this was approved by the FDA about 1.5 years ago, right, shortly after the study came out. And then on top of that, so one other slide on it. So when we go down to different subgroup analysis to look and see, well, is it old patients, young patients? Is it class 2 patients, class 4 patients? Is it men, women? Who is it who benefits from it? What we found was basically everybody seems to benefit from this compared to enalapril or an ACE inhibitor. So it was a pretty strong win. And based on that, it was approved by the FDA. And as we'll talk about in a few slides later from now, it also led to the ACCHA coming together to give a guideline update sort of a little earlier than they otherwise would have, because they did want to let clinicians know that they were endorsing this new medicine. Before we jump into the new guidelines and the new update, I do also want to mention a few words about ivabradine. This one, how many of you guys have seen a patient who's on ivabradine? So we got one. And what about the Entresto or this? Have you guys seen patients who are on that? So a few more, maybe about 3 or 4 of you guys, and that makes sense. So right, I mean that's sort of in my clinical practice. I've been trying to be a little bit more aggressive with moving to the Entresto, as we'll talk about. This sacubitril valsartan or Entresto has gotten a class 1 recommendation as it looks to be better than the current therapy. Ivabradine, well, I'm going to show you the benefit of it. It gets a class 2 recommendation, and it doesn't take the place of our current therapies. It's more of an add-on. So what is ivabradine? You guys remember back to probably pharmacology class or actually some class in medical school where we learned about about cardiac physiology. And as you recall, the sinoatrial node is the cardiac pacemaker. Our native God-given pacemaker depends on this intrinsic depolarization current that tells the heart when to beat. And that depolarization current is based off of this funny sodium channel, which we call it funny channel because it allows sodium to go in as opposed to out of the cell. And it does so, only through this channel. This channel is only found in the SA node as well as in some cells within your eye. It's found nowhere else in the body. Well, so this medication was designed actually almost a decade ago now, and has been studied in both heart failure as well as in ischemia. And this medication, ivabradine, is a selective funny channel inhibitor. And in so doing, what it does is it slows down the depolarization of the SA node and thus slows down the cardiac heart rate. The one trial that looked at heart failure patients randomized patients who had low ejection fraction, so they were ejection fraction less than 35%, and who were already on goal-directed medical therapy. So they were already on beta blockers, ACE inhibitors, and the mineralocorticoid receptor antagonists. And they had to have a heart rate that was over 70 beats a minute despite being on the maximally tolerated beta blocker. As you guys are aware, a lot of patients, we try to put them on goal-directed beta blocker doses, but have some difficulty getting up to the target doses because of hypotension. And so in this study, they looked at patients as long as they had been attempted to be put onto a beta blocker, or whether or not they were on a maximum dose of beta blocker, they were then, if their heart rates were still over 70 beats a minute, they were then randomized into this study. And what the study showed, if you can see here, this is just the take-home figure from the manuscript, looking at the composite primary endpoint, which was death and heart failure rehospitalizations. And they did show about, I think it was like a 15%, or actually it looks like it has ratio is 0.82, so about an 18% reduction in the primary composite endpoint in the patients that received the ivabradine as opposed to the placebo on top of their otherwise standard medical therapy. When we teased out the different secondary endpoints, found that this was primarily driven by a reduction in heart failure hospitalizations and not in all-cause death. They did some funny thing where they defined cardiovascular death in a very interesting way, and by that they were able to then show there was some benefit on cardiovascular death as well, but it wasn't a pre-specified endpoint, so for that reason I wouldn't read too much into it. I really look at this as not a mortality-reducing medication, but more as a morbidity-reducing medication. And then the other thing that I would point out about this medication is when they did their subgroup analysis of at the end of this trial, all the benefits seem to have been in the patients who had a resting heart rate of over 77, or basically higher than 80 beats a minute. And those patients whose heart rate was sort of in the 70 to 80 beats a minute range did not show the actual improvement. So again, while I am actually been fairly aggressive recently and moving my patients from ACE inhibitors or ARBs over to the new valsartan sacubitril combination pill, for this medication, I'm really looking for a much more select patient population. And that's why you probably won't see quite as much of this medication used as you see the other new medicine. But I'm specifically looking for patients my HFrEF patients who are on maximally tolerated beta blockers and still have heart rates that are at least in the 80s, but definitely those whose heart rates are in the 90s or higher, and I don't think they're in shock, I will start this medicine. And I've actually had some good, anecdotally, I've got some pretty good experience with this medicine now with at least a handful of patients, like 4 or 5 patients, that heart rates were just, clinic visit after clinic visit, heart rates were in the 90s and 100s, blood pressure was in the 90s. I couldn't go up any higher on their beta blocker. They were only on a small dose of the ACE inhibitor. And from, just from clinical assessment, and on a few of them from putting a swan in, showed that they were not in cardiogenic shock, gave them the ivabradine, which is started as just a 5 milligrams twice a day. And within a couple of weeks, when they came back to see me in clinic, their heart rates were in the 60s or 70s, and their blood pressure, for the first time ever, their systolic blood pressure was over 100, or was 110, and actually allowed me then to up titrate some of their other medications. So get them onto a better dose of the ACE inhibitor, get them even start increasing the beta blocker, which I really was limited on before. And so I think that this medicine, you're going to be seeing it more and more, and it definitely belongs in our heart failure arsenal. So as I alluded to, there's been this update to the ACC/HA guidelines from 2013. Specifically, this was called the Focused Pharmacologic Update, and it was really designed to incorporate those 2 new meds we just mentioned. The ARNI, valsartan sacubitril, got a Class 1 recommendation to be started in any patient with chronic symptomatic HFrEF that's at least class 2 or 3 who are tolerating an ACE inhibitor and ARB. And I think that's also an important thing to note. The ARNI is a bit more potent than just your ACE inhibitor or your ARB. And so in order to get enrolled in that paradigm trial, the patient first had to tolerate a fairly good dose of valsartan. They had to tolerate like 160, I think it was at least 160 twice a day of valsartan. Now that doesn't mean that if your patient's only on 80 twice a day of valsartan that we can't consider this, but just realize that patient wasn't put into the trial because they were probably concerned that the patient's going to get hypotensive with our new medicine, and they didn't want to stack the deck against the new medicine. So they took patients that could tolerate a good dose of the ACE or ARB. So when I look at patients, if a patient is coming to me follow-up is on at least 10 milligrams of lisinopril or at least 80 twice a day of valsartan, then I consider that patient somebody who I think they should be able to tolerate the ARNI. The ARNI may cause a little bit more hypotension and it may cause a little bit more angioedema. But those are just things to look out for. The other class 1 recommendation that the ARNI got was the clinical strategy of inhibition of ACE inhibitors, ARBs, or ARNI in conjunction with beta blocker is recommended to reduce morbidity and mortality. So it sounds pretty similar to the first one. But this was, I guess the first recommendation here is to actually consider replacing the ACE inhibitor or ARB with the ARNI. The second recommendation here says that you can start it instead of, or it's basically, you can still use your ACE or ARBs. They did come up with a couple of class 3 recommendations for the ARNI based on that trial. Specifically, one of the things is, so the way that this ARNI works is it decreases the neprilysin breakdown of BNP, but there are other things that neprilysin acts on, so bradykinin and some of the other vasoactive peptides. And because of that, if you give it to somebody who's already on an ACE inhibitor, or who's currently on an ACE inhibitor, at the same time they're receiving the ACE inhibitor, they're already going to have, on the basis of that ACE inhibition, an increase in things like bradykinin. You now then increase it more by breaking down the breakdown of the bradykinin, and you can see an alarming rate of angioedema in these patients. So if you're going to start the ARNI, you have to make sure that you've stopped, that they have not received that ACE inhibitor within 36 hours. You have to let the ACE inhibitor wash out before you can start the ARNI. Now, if the patient's coming to you and they're already on an ARB and you're going to switch them to the ARNI for the additional reduction in morbidity and mortality, the ARB you can switch directly to it. You can say, all right, well, you took your ARB this morning, you can just stop that and start the ARNI tonight. If they're taking an ACE inhibitor, you have to tell them to stop the ACE inhibitor and wait basically at least a day and a half. I generally tell patients to wait at least 2 days before they start the new medicine. So they'll go on a sort of a ACE, ARB, ARNI free period just to make sure they wash out before they start the ARNI. The other patient that we would not want to start an ARNI in is those who have already had a history of angioedema with the little bit less potent agents like the ACEs or the ARBs. As far as ivabradine, as I mentioned, it gets a class 2 indication, and it's a lot more specific sort of guidelines into who to start it. It's not just HFrEF with symptoms, but it's HFrEF with symptoms with a heart rate over 70 despite already being on a maximally tolerated beta blocker. So that's why I don't think you'll be seeing quite as much of it, but you probably will be seeing it. And I recently sat down at the Loyola sort of pharmacy meeting to make sure that we got it approved. So both these medicines within the next month, actually I think is starting November 1st, will be on formulary here, so that the patients who come in with this on their med list, you're not going to have to write special orders that patient is to take their home medicine, but you'll be able to just order it from the pharmacy the way you would any other med. So with just a few minutes left here, just a few words on device management. You guys are all aware that, again, HFrEF and HFpEF are distinct in who benefits from cardiac devices, and specifically the ICDs and the CRT devices. That said, there are some other new devices out there. The CardioMEMS device, which I'm not sure if I've talked to you guys much about it, but CardioMEMS is a monitoring device that we have, and CardioMEMS has shown benefit in both HFrEF and HFpEF. And then LVADs, obviously LVADs are beneficial for patients who have advanced heart failure, but specifically from a low EF. LVAD is not something that's going to help somebody who's got diastolic dysfunction. Generally, they don't have a very big heart, and they've got more of a stiff heart than they do a dilated heart. So a stiff heart and a small stiff heart is doesn't really lend a whole lot of room for us to put an LVAD into. And so LVADs are predominantly for HFrEF patients as well. The asterisks here denote the Class 1 recommendations, and see here if I thought I had a slide on it. I don't. So specifically, you guys you guys are probably all very familiar with ICD indications, but the indications are for patients who have a low ejection fraction, 35% or less, regardless of if it's ischemic or non-ischemic, with the caveat that you've done your best to try to let them improve their EF for a period of time before you put the defibrillator in. Because a number of patients who have HFrEF, upon initial diagnosis, will be able to recover their EF to over 35 or 40% with treatment of the underlying disease or just neurohormonal therapy, as we've already outlined. And for those patients, if their EF goes over 40% or at least over 35% for sure, they do not have any, they don't derive the benefit from a defibrillator or CRT. So any patient who's got a witnessed, who has a sudden cardiac death or hemodynamically unstable VT, regardless of EF, they should be getting ICD. And then based on EF, if they have a low EF, despite getting revascularized and getting put on medical therapy for at least 3 to 6 months, those patients should also be considered for an ICD or CRT device. The ICD is a safety net. It's for patients to save lives when patients go into VT or VF. The ICD does not reduce morbidity in any other way other than the morbidity of having a VT arrest and then whatever badness came of that. But the CRT device, on the other hand, actually is therapeutic. It actually reduces both morbidity and mortality, and specifically in a population of patients who have a low EF and have a wide QRS and have at least moderate symptoms. So if they're at least class 3, or I say class 2, it shows some benefit as well, but class 3 heart failure with a low EF and a wide QRS shows the most benefit. And of them, for some reason, it seems that the non-ischemic cardiomyopathy patients that have that dysynchrony benefit a bit more from the CRT than the ischemic patients do, probably because it's not so easy to, if a patient's dysynchronous due to an infarct of their lateral wall, trying to pace that lateral wall, pacing dead myocardium probably doesn't work quite as well as pacing sort of just a myopathic myocardium that still has some viability. So ICDs are indicated for patients to decrease death. CRT devices are to decrease death and as well as rehospitalizations, as well as improve functional classification of patients. They often will see improvement in their EF as well as improvement in their symptoms with CRT. So we do want to identify patients who may be candidates for that. So we're going to say just a few words about CardioMEMS, since CardioMEMS is basically our only device that's been shown to benefit the HFpEF population as well as the HFrEFs. So you guys, how many of you guys are familiar with CardioMEMS, or at least heard a little bit about them? It got a lot of lay press about 2 years ago when it was FDA approved, and we've slowly started implanting them here in appropriate patients. So let's talk a bit more about what they are. The CardioMEMS, as you can see here, this picture here, it's basically a small little sensor in the middle with two little, these are little wings that are made out of nitinol. When you insert the device, it's actually, the nitinol wings are all wrapped around the end of a delivery catheter. So we've got a very low profile. We can insert this through a catheter just like you would a stent or anything else. And when you release it from the catheter, those wings open up and they basically anchor it to the vessel it's going to go in. You can see here from the schematic where it goes. We want to put it into a branch of one of the pulmonary arteries, specifically on the left side, because most people who put swans in, they go onto the right as well, and we don't want to interfere with this thing once it's in. If the patient later needs to get a swan for cardiac output monitoring. And the other part of it is that anatomically, the left-sided pulmonary arteries are a little bit closer to the posterior, at least the ones that are the size that would accommodate this device, are a little bit closer to the posterior chest, which is where we're going to be monitoring the device from. So this device, it gets implanted as part of a right heart catheterization. The sensor itself is basically just it's a pretty ingenious little thing. It's got no wires, no leads, no batteries. It's just a little inert device that has a little circuit, a little electronic circuit inside of it. That circuit is inert, inactive, doesn't do anything until you interrogate it with a little antenna housed inside a pillow. So the patient, not only do they get this device implanted inside their chest, this tiny little sensor, but they go home with monitoring equipment shown in the bottom left here. The monitoring equipment is a pillow that the patient puts on their bed, lays down on every morning, pushes a little trigger that then tells them to lay still while it sends a radio frequency signal to the device that wakes the device up, sends electricity around the device, much the same way that a metal detector works when you walk, when you're walking in and out of a store, making sure you're not walking out with their goods. This thing is going to use it just pings a little radio frequency signal off, activates the device, and the impedance or the conductance of the current that goes around this little, it's about the size of a small paper clip. The conductance of that electrical current is dependent on the ambient pressure. So from that we can get a recording of what the pulmonary artery pressure is in a patient who's at home. So essentially this is an ambulatory swan. And with this information that then is relayed to a website that the physician can have access to, we find that we are able to pick up on changes in those intravascular, so the intracardiac filling pressure, that pulmonary artery pressure, up to about a month prior to when patients are actually getting hospitalized. So this schematic, and we're not going to go through the whole thing, but over here on the right is when a patient gets hospitalized, and when we look back at the different sensors that we have, you can see here usually with less than a week before they get hospitalized is when a patient really develops symptoms, and so trying to then increase their diuretics or change their medication at that point often doesn't work, and they end up in the hospital anyway. So when we start going back and saying, well, there are other signals that we can identify sooner that we might be able to act upon in a more proactive approach and then avoid the progressive decomposition and the hospitalization, we found that there are some things we can find impedance measurement, which is kind of gives you an idea how much fluid there's in the chest, or heart rate variability, which gives you an idea of the autonomic nervous system's level of action, where somebody who's decompensating trends more from being parasympathetically driven to more sympathetically driven, where they would then lose that heart rate variability that comes from the vagus nerve. Those things you can pick up on an ICD, maybe as early as 2 to 3 weeks, but as early as 4 weeks before the hospitalization, where we can see this increase in the pulmonary artery pressure. And so it's based on this hypothesis that this whole CardioMEMS device and trial was designed. And in the Champion trial that implanted about almost 600 patients with the device, with the CardioMEMS device, and then randomized them to either having the information from the device available to the clinicians versus all that information the patients were sending was just going to a black hole and nobody could actually see what the data showed. The patients who the clinicians were actually able to monitor these devices did have a significant reduction in their heart failure hospitalizations, both at the 6-month follow-up period, which was the primary endpoint, as well as when at the time that the last patient had reached that 6 months of follow-up, they went ahead and looked at sort of the patients who had had up to 15 months of follow-up from the first implanted patients or first enrolled patients, and they found there was up to almost a 40% reduction in hospitalizations for patients who were being managed, having their diuretics and their vasodilators managed as an outpatient based off of these PA pressures as opposed to just our standard clinical care that we were currently using. Importantly, when they did a subgroup analysis of the patients who were enrolled in the trial did not specify the type of heart failure. So you could have HFrEF or HFpEF. And when they subdivided the patients into those two groups, they found that the reduction in hospitalizations in the HFrEF patients was about 25%, whereas it was almost 50% in the patients with HFpEF. And so this has become the very first therapy that's been demonstrated to show an actual reduction in morbidity and hospitalizations for the HFpEF population, which is fairly important to note. That said, this device itself is just a monitor. So putting this device in is not going to keep your patients out of the hospital. Putting the device in and then monitoring it and making adjustments based on the readings is what's going to help you here. So this is indicated for both patients with HFrEF or HFpEF, but specifically those who are class 3 and have a history of prior hospitalizations. And that's essentially who we're looking for to put them in here at Loyola. So in our last -3 minutes here, I'll just go through a quick summary. Heart failure is not a disease, but it's a syndrome, and it's a very heterogeneous one at that. So it's important to figure out if they're HFrEF, HFpEF, both in terms of figuring out what medications they might benefit from, as well as figuring out helping you hone your differential diagnosis and figure out what the underlying disease is, because we need to make sure we're treating that. If they've got arrhythmic disease, they need to be treated for their AFib or their atrial tachycardias. If they've got coronary disease, you consider revascularization or at least medical therapy for that. And if they've got more more interesting kinds of non-ischemic cardiomyopathy, then they need to be treated for whatever the process is there. As far as the therapies we know that patients benefit from, HFrEF benefits from goal-directed medical therapy, specifically the neurohormonal blockers, including the new medications we have, the ARNIs and the ivabradine. They also benefit from ICDs and CRTs in appropriately selected patients, and then obviously for those who are very advanced, they benefit from VADs. For the HFpEF patients, we don't have any proven therapies, with the caveat that CardioMEMS looks like a proven therapy, although it's, again, that's really for highly selective centers that are going to have a heart failure clinic that will actually be able to monitor the patient and adjust their other medicines, because the device itself is not what's keeping them out of the hospital. And then potentially spironolactone or other mineralocorticoid receptor antagonists may actually be a benefit here, so that's just more to come. Important every time you see a patient to figure out what their volume status is, and if they need diuretics, use that in your armamentarium. Important to stage in class every patient, every encounter. Consider CardioMEMS if they're class 3 and they've been getting admitted, especially if they get admitted more than once in a year. Those are the patients that I'm really think that might benefit the most from this. And then finally, if they do appear like they're advanced, if you do think the patient's approaching stage D, even if it's just you're not sure, that's the appropriate time to then refer them to see Dr. Haru or myself or an advanced therapy specialist. So I think that's it. If you guys have any questions, I'm happy to stick around. Sorry I went over a little bit. This is actually, that's all your stuff, right? Okay. Yeah.